Well, hello, everyone, and thank you for joining us today. We are going to be talking about a physician's guide to documenting acuity in COVID-19 patients. We'll be talking understanding the ICD-10 terminology and the guidelines that matter. So if you could please go to the next slide. And the next one, please. Excellent. Thank you so much. My name is Ariana Noonan, and I'm with Nuance, and just a couple of housekeeping items for you. Today's presentation is scheduled to be an hour in length. It's possible it will not go that long. You'll all get some time back in your day, or we'll have plenty of time for your questions. All participants right now are in listen-only mode, and we'll be taking questions via the Q&A function at the bottom of your screen, and I'll be facilitating those at the end. The presentation slides will be sent to you in the thank you email, and the recording will be available to you for 3 months. We're also working on getting this information up on the CDI client portal for Nuance CDI clients, so you'll see it there probably in the coming days as well. And with that, I'd like to introduce our speaker today. It's Dr. Victor Freeman. He's a national medical director here at Nuance Communications, internal medicine physician and former hospitalist. His master's degree is in public policy, focusing on health policy and ethics. And he has spent 8 years working with hospital medical staffs, focusing on clinical documentation improvement for optimizing quality and clinical performance profiling. So with that, Dr. Freeman, thank you very much. Oh, Victor, you might be muted.
There we go.
There we go.
All right. Thank you very much, Ariana. Let's hop in. As the nation faces a massive health system crisis in the face of the worldwide COVID-19 pandemic, I commend all the overwhelmed acute and critical care physicians and advanced practice providers that are often struggling to provide care to more and more COVID patients. I specifically designed this 30-minute presentation for 2 purposes. One was to explain why we as care providers, even during this crisis time, must still focus on the documentation of key COVID-related high acuity diagnoses in order to optimize COVID patient care now and in the future. And 2, to give basic knowledge and skills, and even a tool for ensuring accurate and complete documentation under ICD-10 coding rules to more effectively capture acuity in COVID-19 patients. This course highlights the top 20 diagnoses that will directly affect the risk and severity adjustment calculations for severity of illness and also for risk of mortality. It will also focus on 30 key comorbidities that are most likely present in the high-risk patient populations as identified by the CDC. We also will be talking about a summary of key documentation rules that are important under ICD-10. And we're going to introduce you to a tool which is a never miss checklist plus those top 30 comorbidities in written form so that you can use them for educational purposes or for following groups of patients. Let's talk about the new normal for acuity documentation. While we may no longer have the time to document extensive patient histories or long lists of comorbidities, we must be sure to capture the most relevant high acuity diagnoses that help us to screen, manage, and track the growing number of COVID-19 patients. That analysis and tracking can only occur with ICD-10 codes and the specific terminology that's attached to each of those codes. Fortunately, physicians do not need to learn the key ICD-10 codes. They simply need to learn the key diagnosis terms and then be sure to document those terms when clinically relevant. The hospital coding team will convert those terms to the appropriate codes, but we must understand that in creating codes, their hands are tied. They cannot code a high acuity term unless the physician uses the appropriate codable terminology. And while physicians do not want to take the time to learn all the ICD-10 codable terminology, you who are viewing this webinar are in luck. We're going to hop in and talk more specifically about what makes things work. We're going to start with the why. Why capturing never miss diagnosis is so important. There's never been a time when it's been more important because we're going to use it for patient screening, for the allocation of field hospital or acute critical beds. We're going to use it for screening for treatment option determinations. We're going to use it for patient management to alter or add treatments. We're going to use it to determine experimental, compassionate use and other types of therapies. We're going to use it for patient tracking, both outpatient, inpatient, and then in post-discharge settings. And more importantly, we're going to use it to assess care efficacy based on acuity and based on a number of demographic variables. We also are going to be doing some more difficult things like ethical decision making if we ever need to do any care rationing or DNR status determinations. In fact, we might be doing that in a post hoc basis where we're looking to make policies for any future care rationing or DNR status determinations in the event that we have a recurrence that happens this fall or winter. Of course, we're going to be using this for epidemiological analysis and reporting, for looking at any next steps in case there is a further epidemic or a resurgence. And last but not least, we use it for clinical and public health planning for that enduring pandemic or that future resurgence. Let's now talk about the top 20 never missed diagnoses for COVID-19 patients. First and foremost, you should always capture any documentation based on your clinical presumption and your treatment or workup plan. That is crucial for clinical validation. When it comes to pneumonias, please make sure you always classify them as bacterial, viral, fungal, or something else. There is no acuity to a pneumonia until you have documented that. COVID pneumonia, you always can put down viral pneumonia due to COVID. Please make note, you can only call a pneumonia a COVID pneumonia if you have a positive viral antigen test. This is an important concept. We do not make any presumptions around COVID infection. Also, there might be some superinfection. It's bacterial. You can always add that in to the mix. The single most important thing that you can document are the terms acute respiratory failure. And yes, all three words matter. And please document any clinical findings or clinical criteria that you use at your hospital in order to back that up, because we want that fully clinically validated. When it comes to acute respiratory failure, we want to make sure we understand that term. It does not require a patient to be on a vent. It does not require them to be intubated. If you're thinking moderate or severe respiratory distress, please write acute respiratory failure. Please remember other terms like respiratory distress and pulmonary insufficiency do not reflect acuity. Oftentimes, we're going to have patients who have acute on chronic respiratory failure. Any patient in chronic respiratory failure is a patient who was on 24/7 home oxygen. These patients are at high risk for COVID. This is true even if that COPD was stable. When you document chronic respiratory failure, please put down oxygen dependence and the type, even if it's just nasal cannula. The only time you should be using the term respiratory distress is if it's very mild, or if you're using it in the term acute respiratory distress syndrome. When it comes to sepsis, it is important to recognize that the government and the IC10 coding system do recognize 3 levels of sepsis. Our traditional sepsis by SIRS criteria, severe sepsis, which is with organ failure, are now often referred to as SOFA criteria, and sepsis with septic shock. I will not get into the debate of SIRS versus SOFA, but please understand that if you miss the concept of sepsis by the SIRS criteria, it will have a profound impact on capturing severity of illness, because you will not find that skipping this, simply waiting for organ failure, will get you the same level of acuity as simply putting down the SIRS criteria, those symptoms. Please avoid terms like meets SIRS criteria or meets sepsis criteria or SIRS due to infection, because these will not be coded. They will not be interpreted. They do not reflect acuity. If you're having troubles with this, please have a discussion with the medical staff because you can begin to identify some of the STIRS criteria as part of early organ failure. Tachycardia of STIRS can be an early sign of vascular system collapse or failure. Tachypnea could either be early pulmonary organ failure or early compensation for lactic acidosis. The reason I say this is it's okay to document early sepsis or even mild sepsis to reflect the high acuity that's there. Please note, don't get too clever. Pre-sepsis will not work for ICD-10 acuity capture, but early sepsis and mild sepsis will be documented as sepsis and will be understood as being based on the STIRS criteria. When in doubt, you're going to have to use the medical staff approved criteria for sepsis, but I wanted everyone to be aware that the 3 levels of sepsis are what's recognized under ICD-10. We also want to make sure we're capturing negative cardiac events as they come up. Cardiac demand ischemia, and even the more serious version, which is myocardial infarction type 2, can both be seen in a number of COVID patients, especially when you're having ischemia that's associated with shock. I will leave it to you and the American College of Cardiology to formally define these, but please make sure you are recognizing that both of them are very important to capture when it comes to acuity. Also, we want to make sure that if you have known or presumed type of shock, especially if that's cardiogenic shock, we always want to make sure that we are capturing that. Because of the seriousness of ventricular arrhythmias, please make sure you're putting down terms of ventricular flutter or fibrillation. Those are the terms that will actually reflect acuity. And of course, if there's cardiac arrest, please make your best effort to know what you believe to be the known or presumed cause of that. Most typically cardiac, but given the respiratory problems of COVID, that might be the trigger ultimately for the cardiac arrest. There are also some other key diagnoses that I would never want to miss. Septic encephalopathy or any other type of metabolic encephalopathy, perhaps related to diabetes, carry major acuity. I'm raising the issue of encephalopathy because it is much more impactful than the term delirium. And please, please, please stop using the term altered mental status, which is a very vague term and carries no acuity. Coma is also a key diagnosis, and it's certainly going to be a far better than simply saying that people are unresponsive. Please note the term coma has acuity, unresponsive does not. If your hospital uses Glasgow Coma Scale findings, please document those when relevant. The more serious versions of those are quite codable and do affect acuity. And another condition that's out there is a disseminated intravascular coagulation, DIC. It's often a bad prognostic signal. There are other ways in which this is being described. The other terms are not associated with comorbidity, so you need to determine whether or not you're going to use this terminology or another terminology that may not capture the full acuity of the seriously ill patients. Let's talk now about some of the key comorbidities that are likely present in high-risk populations. When we look at those populations, what we're noticing that these are populations that were identified by the CDC, and they have a number of significant comorbidities that are commonly seen there that we want to make sure we review to ensure that we are capturing full acuity in COVID patients. Please note, this is not a comprehensive list of clinically relevant conditions. Many comorbidities, like acute bronchitis, may be clinically relevant, but they are not high acuity. So I'm not presenting a list of all possible diagnoses that can come up in these situations. I'm focusing on the high acuity ones since they affect severity of illness and risk of mortality. Given the COVID virus tendency to often target the lungs, let's begin with lung disease. And as you can see here, asthma and COPD will probably be the most common chronic lung disease patients that will be affected. Always, always specify when there is exacerbation with the COPD or asthma. That term with exacerbation is key. Simply describing it clinically is not sufficient. Please make sure in order to ensure that it's appropriately coded, that you specify COPD or asthma with exacerbation. With COPD, you can also specify when there's an acute lower respiratory infection. Again, that's what captures acuity there. Even though that's a vague term, it does carry acuity. And when it comes to asthmatics, please make sure you specify if their status asthmaticus. That is crucial. There may be other types of patients that are coming in that are facing different types of special issues. You might have some young adult patients coming in with cystic fibrosis. You especially want to make note for that particular disease when they're with pulmonary or other types of manifestations. Please specify what those are, crucial for capturing the acuity for these high-risk patients. Of course, you'd also want to make sure you're capturing high acuity lung conditions like lung abscesses, pyothorax. When you do that, please specify with or without fistula. And of course, acute pulmonary edema. We also want to make sure we're capturing pneumothorax, hemothorax, and any pleural effusions. Cardiac conditions are also going to be quite important for us. Congestive heart failure is going to be one of our most common ones. Please note, putting down CHF alone does not carry any acuity, no matter how you describe it. We always need to specify if it's acute, chronic, or acute on chronic when we have that information. But even that's not enough. If we truly want acuity, we need to know if it's systolic, diastolic, or combined. If you do not know these, please do a quick check of a cardiology note, an outpatient record, or a prior admission to see what their chronic state is, whether they've had problems like this before. The type of heart failure is crucial for capturing acuity. There are terms that are out there now that include heart failure with preserved ejection fraction, which will code to diastolic, heart failure with reduced ejection fraction, which will code to systolic. Please contact your cardiology department to get better clarity on how these terms are being used, but they're pretty straightforward. The most important thing, however, is you still got to specify acute, chronic, or acute on chronic. We also want to give any specificity that we can to any specific type of cardiomyopathy when it is present. And of course, when we have specific arrhythmias of any type, we do want to make note of them. We also want to capture unstable angina. And of course, we want to capture myocardial infarctions when they occur, always specifying if it is STEMI or non-STEMI. Now, there is an unusual thing that many physicians may not be familiar with, but that is acute MI can be a secondary diagnosis for up to 28 days after the original event. So they may not be coming in for the MI. If they had an MI within 28 days, it's considered still acute and a secondary diagnosis. If they were having a second MI, there's a different term called subsequent MI. So a new MI within 28 days of a previous one is called a subsequent MI. So we do have different terminology to differentiate. Clearly, patients with diabetes are going to be important. We want to make sure we're specifying when they have hyperosmolality, ketoacidosis, or hypoglycemia. We always want to note whether it's with or without coma. There are more elaborate things that we find in diabetic patients. So whatever your endocrine folks are saying to capture, make sure it is documented clearly. But more importantly, we always want to specify if we believe it to be type 1, type 2, caused by an underlying condition, or caused by a drug or chemical. Running into patients with a wide range of types of immunodeficiency, I did want to give some special emphasis on AIDS. The patient is HIV positive, and they have at one point in time had or are currently having an AIDS-defining condition. We need to document AIDS to separate that from simply being HIV positive. Once they've had an AIDS-defining condition, the documentation should be AIDS. There are a wide range of immunology things that we need to have specificity on. They do not have acuity until we get that. So we do need to check the oncology, hematology, immunology records to ensure that we have specificity around leukemias, immunodeficiency syndromes, aplastic anemias, and any bone marrow failure syndromes. Also, there might be chemotherapy or other drug-induced pancytopenias. These carry significant acuity. There might even be some immunocompromise that's due to heavy steroid use. Again, make sure we're capturing these whenever possible. Clearly, there are other things that are coming up, and renal disease is going to be one of those. End-stage renal disease must be explicitly documented. Simply saying that they're receiving regular dialysis does not have acuity. Remember, the coding staff is not allowed to interpret. They're requiring you to use codable terminology. If they have chronic kidney disease, we would like to know the stage. We will need to get that from probably an outpatient record or from some renal notes. Stage 4 and stage 5 do have significant acuity, so we do not want to ignore that. Bedridden patients are going to be at risk for COVID infection also. Quadriplegia is an important one for us to capture, and we'd like to know the cervical level if we've got it, or complete or incomplete if we've got it. There's an important concept that often gets overlooked, and that's something called functional quadriplegia. This is not necessarily a spinal cord injury. This is more related to atrophy or contractures being the reason for the quadriplegia. This might be seen in a large number of dementia patients. It's not a neurologic quadriplegia, it is a functional quadriplegia, and it matters a great deal for capturing acuity. Also, you may have patients that have a spastic quadriplegic cerebral palsy. This term also carries significant acuity. We have a large number of patients that, and especially in the cities, that are homeless or impoverished, and these are also patients that are at high risk for COVID infection, mostly because of their inability to protect themselves. When it's relevant, please document malnutrition. Your first call should be the malnutrition. Your second call should be to a dietitian, because we always need to specify the malnutrition as mild, moderate, or severe. That is done based on Aspen criteria or other criteria, often use the Gomez criteria. But the dietitian should generally know these criteria, be able to implement them. Although there is not a lot of acuity associated with simple malnutrition unspecified, mild, moderate, and severe do carry some acuity. Race and ethnicity do not change acuity, but that, along with morbid obesity and body mass index, are still important variables for us to capture for a lot of the demographics we're looking at in both clinical and public health analysis. Let's now talk about some of the key documentation rules. It's important you understand these rules. They are basic for all documentation, but they're particularly important as we're looking at acuity in COVID-19 patients. The first issue is that all major diagnoses must be clinically validated. That means the first time you put them down in the medical record, you need to back them up with clinical criteria or simply with your clinical findings. Either is fine, but the clinical validation is important. What we do not want is people putting down diagnoses that are not clinically validated just to puff up how sick patients are. You can list the diagnosis as a presumptive, probable, likely, or suspected diagnosis, and it will be coded as that diagnosis unless and until you present clinical information that indicates another diagnosis. There's an important exception here. COVID-19 infection, you cannot say presumptive, probable, likely, or suspected and have that coded. You must specify that you have a positive viral antigen test in order to use the term COVID-19 for infection. Unfortunately, we do not have a code for COVID-19 antibody positive. Hopefully that will be coming soon. Right now, we're looking at active infection, and so that is the only time you can use that. The terms presumptive, probable, likely, and suspected can be used for other diagnoses, but they cannot be used for the coding of COVID-19 infection. You can have a differential diagnosis list as long as you want. Please, please, please specify one presumptive diagnosis, because that's the only one that's going to actually be coded until they get more information from you as to what the actual diagnosis is. When we're doing this, you are allowed to use the term possible. Please avoid doing that. It indicates such a level of uncertainty that it is a red flag to managed care and to payers that you're completely unclear on what you're treating. So the terms would be presumptive, probable, likely, suspected. And if you're going to use a differential diagnosis list, please specify one of them as a presumptive diagnosis. Please remember, if you get new clinical information, you can always say, I limited this previous diagnosis. Here's my new diagnosis. The coder will simply make the change. Any auditor will see it, and it is expected to occur. We always, always, always want to capture the acute, the chronic, and even the resolved diagnoses in that discharge summary. The discharge summary is a continuity of care document. So it may be all that's transferred to any follow-up care providers. So they need to know what the patient came in with that resolved, as well as any ongoing acute and chronic conditions. Now there is a sad area we need to focus on, and that's the death notes. We often don't put a lot of time into these. Clearly it's sad whenever we lose any patient, but we still need to have all the acute, the chronic, and even the resolved diagnoses in there, because as we're calculating a lot of the risk and severity adjusted mortality rates, we do need to make sure we're capturing all of this information. So let's talk about the tool we have here. It's going to be basically 4 pages that are laid out in a ledger size format. So you can print them out, fold them in half, and they will actually make a booklet. Or you can attempt to print them out individually in order to post them places, but we've designed them so that you can put them up as a ledger size presentation in different areas. We have organized them by major organ systems. We anticipate they're more likely to be used by medical directors, whether it's the medical director of the ED or critical care or quality, utilization review, the chief medical officer. We also anticipate the clinical documentation team may use them and post them in critical areas, because the most useful part of them is for education. Just so people know the terms, we've also included ICD-10 codes just in case people had any questions about that. We have not focused in this presentation on coding, but I want to make sure you had a tool that was a quick and easy reference, looking at the never miss conditions, as well as the comorbidities in the CDC's high-risk patients. If you have more specific questions about coding, I refer you to the AMA. They do have an AMA Physician's Guide to COVID-19, which has a large number of resources there. The most relevant one in this particular situation is going to be special coding advice, where they will take you through specific scenarios on the appropriate ICD-10, as well as CPT and HCPCS coding. We are not endorsing the AMA's website. They are not in partnership with us, but I did want to make sure we were pointing out important resources if you wanted more specific coding information from a physician point of view. Please be sure to work with your own health information management, your HIM department, the coding team that's there, if you have any particular questions. Also, your clinical documentation team, nurses, our coding professionals are a great resource for getting a lot of your questions answered. But for now, we're glad to answer any questions that we can.
Thank you, Dr. Freeman. And we do have one question. It's come in. It says, I've seen in other presentations that the provider can document COVID, although test negative because high suspicion due to symptoms.
I keep inquiring about this. I am told quite explicitly that a coder may be required to document COVID-19 because the physician has declared it to be present. However, the expectation is it will only be declared to be present when there is active COVID infection as demonstrated by a test. Please be careful in this area. There are lots of rumors out there that hospitals are calling every patient that comes in COVID positive in order to get higher payment for that. That would be fraud, and you do not want to get caught in that trap. So you do want to make sure you are always confirming that you actually have a COVID positive patient. Now remember, you can call something suspected COVID while you're waiting for the test results to come back. That is clinical communication that you will have with your colleagues. It will not be coded as suspected or presumed. Once you have that test back, please make a specific note that you have that test, and then it can be coded as COVID-19.
Thank you. And second question, does CT count as a test indicating COVID infection?
That's an interesting question. I have never heard anyone in the coding world indicate that you can make a definitive call of COVID with a CT scan. You can make a definitive call of a viral pneumonia, but again, until that test is back, you're not going to know if that is COVID.
Okay. Suggestions to handle patients that have no respiratory symptoms or diagnoses, but are simply hospitalized because they have a positive test.
Again, I would look to see if they're in any of those high-risk groups, even though they're not presenting with the traditional lung stuff. Many patients are coming in with GI symptoms or kidney symptoms. Some of them are coming in with stroke. So whatever the reason they're in, if they are positive, make sure you are documenting the COVID-19 infection based on a positive result, and then capture the relevant comorbidities. Now, I'm not able to go over all the comorbidities for all types of patients, but your clinical documentation team should be able to give you any specific comorbidities that affect acuity in patients that I have not covered. So I don't have special instructions there. Remember, anyone that comes in that's positive, and my wife happens to be a nurse working in a mother-baby unit, there are plenty of pregnant women coming in who are COVID positive, have to be on special precautions. We always want the COVID thing captured because the simple diagnosis of COVID-19 changes acuity. And given the amount of resources, nursing resources, hospital resources that go into caring for COVID patients, we want to make sure that it's always documented, even if they're asymptomatic for that, but in the hospital for an unrelated reason.
Okay, next question. How to document patients that remain positive for 8 weeks, but they were never admitted for COVID? They were found positive during the screening process.
If they were found positive a while ago, and you're seeing them now and they are still positive, that is still considered active infection, even if they're asymptomatic. I know some patients are holding on to a positive test for long periods of time. Unfortunately, the coding system does not necessarily match how we might look at things clinically. It is an administrative classification system. So if they are positive and you are seeing them, we put down positive to indicate that they have an active positive test.
Thank you. Looks like there are no more questions, but I will just reiterate for everyone, the document that Dr. Freeman mentioned related to the never miss and the comorbidities, that will be available sent to you through the thank you email, so you will be receiving that after the webinar. We're also going to be posting it on the CDI portal page as well, so that we, for Nuance clients, so that they can access it there as well. So that'll be coming in the next couple of days. Looks like we have a statement that just came in. The coding guideline states, in this context, confirmation does not require documentation of the type of test performed. The provider's documentation that the individual has COVID-19 is sufficient.
That is correct. But remember, when someone comes in to audit this, if you've made that declaration without a positive test, you're at risk.
One more. How do you code a patient that was COVID positive last month and gets readmitted for PNA? Do you still use U07.1 if repeat COVID is negative?
I would not. Again, I'm trying to keep you safe. And the safest way to do it is you only use the U071 if you have a positive test.
Okay, I think that is everything that's come through. So you'll be receiving, as part of the thank you, you'll be getting the slides, access to the recording, as well as the never miss and comorbidities list that you'll be able to utilize as a booklet form or post as a poster in a place where people can see it. And additionally, we will also include, when you click out of this, you'll get access to a survey for us. This would be really helpful just to make sure you got value out of this. We want to know. We also want to know if there's other topics that you're interested in hearing about. So with that, I will say thank you, Dr. Freeman, very, very much. And thank you all for joining us today, and have a pleasant day.
Thank you all.